I'm Marielle Wondergem. I work at the University Medical Center in Amsterdam in the Netherlands. We're an academic medical center and we are a referral center for AML patients of our region. That is about 4 million people. And they are referred for leukemia treatment, a lot of the time in study, both inpatient and outpatient. And we also perform autologous and allogeneic stem cell transplantations. And I want to present this case to you because it has 3 characteristics. At first, the diagnosis, that immunophenotyping is very important to come to the right diagnosis. Second, to keep your cytogenetic results in view because they can change your treatment immediately. And lastly, I want to deliberate a bit about the order of mutations in AML. So this lady, she was 33 years old at the time she presented. And she had just given birth to a daughter after IVF. It was a very strenuous procedure, but when she still felt dizzy after 9 months and fatigued and not well, she went to her GP and he didn't even find much because she had a normal hemoglobin, she had normal thrombocytes, but she had a leukocytosis, and at that point blasts were seen in the peripheral blood. So that's why she was referred to us, and we did a bone marrow. And we saw a very packed marrow with a lot of eosinophils and very large megakaryocytes and blasts. So at that time we thought, what kind of blasts are these? And that's what I want to point out because it's very difficult to guess whether a blast is a lymphoblast or an AML blast or myeloid blasts. And in fact you shouldn't. And I always compare it with babies because when you see a baby it's very difficult to guess its sex. And if you're wrong, your relationship with the parents is not very good for the next, I don't know. So some parents help you and they dress their children appropriately. And some blasts also help you because they have hour rods or they have a positive Sudan black. And they help you by telling I'm a myeloid blast. But when they don't, you don't know. So for that we have immunophenotyping, and we need immunophenotyping because some blasts look like lymphoblasts and myeloblasts. They could be any. And immunophenotyping looks at surface characteristics of cells. And we have decided on markers that define a lineage. So we have MPO. When you are MPO positive, we say that you have enough characteristics to be of myeloid lineage. And with the T lineage, it's also easy, you need cytoplasmic or surface CD3. With the B lineage, it's a bit more difficult since you look at the CD19 expression, and if it's stronger than normal B cells, you only need 1 of the 3 markers that are on the slide, and if it's less than normal B cells, you need 2 of those markers. So when we go to our patient, she had CD19 positivity and she had all 3 markers. So she definitely defined as a B lymphoid lineage. However, she was also MPO positive. So at that time, she defined for 2 lineages. She was a mixed phenotype acute leukemia. We got also her karyotyping and it showed a translocation 922, and that was confirmed by BCR-ABL positivity. And eventually, we also found EVI1 positivity in her. But she was diagnosed with a mixed phenotype acute leukemia with translocation 922, which is very important for the treatment because you need a TKI, tyrosine kinase inhibitor. Although it's a very rare disease, this mixed phenotype acute leukemia with 922, we had a second patient presenting within 1 year of the first, and at that time, of course, we were focused on it being a possibility. He did not have many complaints, had a pain in the chest, had a syncope once, also went to his GP and had an anemia and also a leukocytosis with blasts. His blasts also had characteristics of both lineages, but it was a bit more difficult even because he had 2 populations. One population had characteristics of the B lymphoid lineage and MPO, so that was a mixed phenotype acute leukemia. However, his other population was just a common B ALL. So he was in fact biphenotypic and also bilinear. He also presented with a translocation 922 and a BCR-ABL transcript and EVI1 positivity. the difficulty now is that we have 2 patients with mixed phenotype acute leukemia, and we have to decide how to treat them because they have characteristics of both AML and ALL. In the past, some centers have treated these patients as an AML, and other centers have treated these patients as an ALL. And because they are very rare, it took some time to gather data on all these patients, but after some time, when we compared the patients treated as an AML and compared the patients treated as an ALL, the ones treated as an ALL did better. In fact, our first patient, which we treated at that time as an AML, as was usual in our center, fell between the ALL patients. Good for her, she reacted to the AML treatment, of course combined with dasatinib for the 922 translocation, and she was consolidated with an allogeneic stem cell transplantation in first complete remission. The second patient presented a year after. At that time we had changed policy based on literature, and of course he also had 2 populations, one being completely ALL. So he was treated with an ALL scheme, again combined with dasatinib, and consolidated with an allogeneic stem cell transplantation. And I asked myself, are we looking at a strange form of CML blast cries, or is this really an acute leukemia? Because when we look at the translocation 922, we know it's a prerequisite for the diagnosis of CML. However, in acute leukemia we find it. We find it in ALLs, more often than in AMLs, but we also find it in mixed phenotype acute leukemias. And whereas the ALL has a certain transcript, the P190 transcript, and CML has the P210 transcript. Both transcripts can be seen in the mixed phenotype acute leukemia. EVI1 was found in both these cases, can be overexpressed in leukemia and in solid cancers and lead to impaired cell differentiation and upregulate cell proliferation. And it has been found in CML patients too. Not at diagnosis, but later on. And it was found that patients expressing EVI1 did worse, had a shorter overall survival, a shorter event-free survival. Whereas in leukemia, we know in acute myeloid leukemia, it's a very poor prognostic feature. In ALL, we don't know. And in CML blast crisis, it's frequently observed, and its expression is much higher than in the chronic phase patients. With the mixed phenotype acute leukemia, it's still unclear. And we looked in our cohort of patients, and about half of them had EVI1 positivity. Half of them had a mixed phenotype acute leukemia. So perhaps it's more common than we think. And what I thought is, and this is a hypothesis, of course, but it's always nice to deliberate about this. When you have first a translocation 922 and you develop EVI1 on the go, you might go from CML chronic phase to blast crisis. Whereas probably when you have the EVI1 first and then the translocation 922, you might end up having a mixed phenotype acute leukemia with 922. Of course, this hasn't been proven at all and will be very difficult due to the rarity of these patients. But what's important in this case is that these patients were both classified as a mixed phenotype acute leukemia due to immune phenotyping. Because it was published in literature that ALL treatment was better for these patients, we treated our second patient different as the first. Luckily for the first patient, she also did well, and that was probably due to the dasatinib, to the tyrosine kinase inhibitor. That's of course a targeted treatment for the 922 translocation they both have. And in fact, they're doing both very well. Our first patient went back to London because she was an English woman, and the first patient is still in Amsterdam, and they're both still in complete remission, both still using dasatinib. Our hypothesis, although not investigated further, came from the fact that CML is a stem cell disease, and EVI1 is known to happen in stem cells. And the mixed phenotype acute leukemia, especially in the first patient, looked morphologically like a CML with a lot of megakaryocytes and the eosinophils. And that made us think, might it be the order of things that some patients start with a CML, acquire the EVI1 mutation that makes them proliferate more and go into blast crisis, whereas other patients appear to present with already an acute leukemia, might that be because the EVI1 was already present at the time that the 922 happens? In these patients, there are no randomized studies. So that's why registries were very important here. So the larger centers, seeing a little bit more of these patients, collected data on the characteristics of the leukemia. Most of the time they're mixed B lineage and myeloid lineage leukemias. And they registered their treatment, whether they were treated like an AML or as an ALL. And the patients that were treated as an acute lymphoid leukemia did better in the long run. And apart from that, of course, we have the translocation 922, and like in acute lymphoid leukemia, where we also add tyrosine kinase inhibitors, we should do that when we have a mixed phenotype acute leukemia.